me introduce then our speaker. Thank you very much for agreeing to share with us your knowledge and your experience in mental health and specifically focusing on children and adolescents. So Dr. Young obtained her medical degree at the University of Pretoria, and then she trained in psychiatry in the University of Cape Town, and further completed the fellowship in child and adolescent psychiatry at Red Cross War Memorials Hospital in Cape Town. Dr. Young focuses primarily on children, adolescents, young adults, and families struggling with a broad range of psychiatric disorders. And she believes in offering a comprehensive assessment determining biological, emotional, and social factors that contribute to the presenting symptoms. So she is really very experienced and very knowledgeable about the topic. Our topic is self-harm and suicide in adolescents. What are we missing and how do we cope? Miriam, thank you so much for sharing your knowledge with us tonight, and I'm looking forward to your presentation. So over to you. Thank you.
Hi, evening everyone. Thank you, Margot. Let's see if I can share my slides and my knowledge.
Always a challenge, the technical parts of it.
Isn't it just? No, we'll get it now.
There we go.
There we go. Oh yeah. Are we all good?
I think you can go ahead.
Fantastic. Okay. Just give me a shout, someone, if you lose me or if, yeah, you can't hear me. So thank you so much for that lovely introduction. So like Margot said, I see there's a raised hand. I just want to pause for a second and make sure that I'm still good.
I think if there are raised hands, then our conference department will give attention to it, so don't be distracted by it.
Oh yeah,
if there's something that relates
as long as
to
everyone
you,
can hear me and that the raised hands aren't pointing at me, would be good.
Yeah.
So like Margot said, I have been a little bit around our country. I'm originally from Joburg and I come from a family of teachers. I managed to study and work in some of the most beautiful places around our country, and I've been here in Cape Town for the last couple of years. And I think the important bits, besides the educational bits that you need to know about me, is that I am a working mum. So I'm a mum, and so I think I've got a fair understanding of the sort of real juggle that we all have, and how, I'm a doctor, but I'm also a mum and a sister and an aunt. And so I'm aware of how things can sometimes get a little bit complicated. And so I wanted to keep that in mind when I was preparing this evening. So I was thinking about who would maybe be listening to a talk about adolescent mental health. And I think it could be a lot of different people. So Donald Winnicott is one of my favorite authors, and he's a pediatrician, and he said really, really wise things like there's no such thing as a baby, and a baby alone doesn't exist. And he was talking about how children always grow up in a system. And even if teenagers feel like they are all independent and want to do their own thing, that's not actually true. They are growing up in a system of a family and their friends and their parents' friends who they might confide in at the bar on a Saturday night, their teachers, their coaches, their medical professionals, their mental health professionals. And so a lot of different people might actually be encountering teenagers who are struggling with suicidal thoughts or self-harm behaviors. And some of us might even have multiple hats on. We might be parents and therapists and doctors and aunts of someone who's having a hard time. And so we might be looking at this topic from multiple perspectives. And so I wanted to talk about something that's obviously a really triggering topic. And I think it has to be a triggering topic. I think we have this innate human instinct for survival. We get born with an instinct to live. And so just the topic, the nature of the topic, self-harm, suicidal thoughts, is going to completely go against that innate instinct. And so that is something that we are naturally primed to see as a threat to our survival instinct. And so we are naturally going to react with anxiety, and our body is going to react with a stress response, a trauma response. And so it is a really hard topic to think about and to listen to. And so what I'd really like to cover this evening is to, I think, just reinforce a little bit of awareness around the topic, and provide a little bit of a fresh perspective to think about some strategies to help these distressed adolescents, and to also help us face our own uncertainty and our own discomfort. I love this quote from Joe Louis, who is a boxer, and who famously said, everybody wants to go to heaven, but nobody wants to die. But these children, they do. And I'm not completely unfamiliar with this sort of anxiety response. So this is a picture of me in the early 2000s with my team that I worked with in Limpopo in the bush. So I was there for internship and community service, and then I loved it so much that I stayed and I worked as a medical officer working in pediatrics, and also in psychiatry. And that was my plan, that was my dream. I was doing my time so that I could go specialize in pediatrics, pediatric oncology, so children with cancer. And so I was there at the height of the HIV pandemic and at the beginning of the ARV rollout. And I found it really difficult. So I had a full ward of children who were all dying, and where we were desperately trying to fight this enemy, this illness. And so the parents wanted their children to live, the children wanted to live, they were fighting this illness, and it really felt quite disempowering and feeling powerless to kind of fight this illness. And eventually I found it really hard, and I didn't want to tell another parent that their child was going to die. And I ended up leaving pediatrics, partly because I loved psychiatry and I really wanted to do that. And it's been a roundabout way that I've kind of come back into child and adolescent psychiatry, and I'm working with children again. And I'm now confronted with a different type of death, because now, I kind of thought children aren't going to die if I go into psychiatry, but actually they do. Eating disorders, mood disorders, depression, suicide, there are actually deaths in psychiatry, but it's a different kind of death, because the illness itself will often turn the patient into the enemy, because for the first time now you're dealing with an illness that actually is making the child not want to be alive. And that can be really hard for parents and the system around the child, and for healthcare workers, because you're now not working with the child to fight this unfaced enemy, this illness. The child is actually forming part of that. And so again, it goes against this innate sort of survival instinct, and it's really hard to understand. And I think it contributes a lot to the kind of stigma that goes around mental wellness and mental illness. But unfortunately, it is actually a pretty problematic and common problem. So if we have a little look at the actual numbers around this, so going back to around the time that I started specializing in child and adolescent psychiatry, sort of 2011, 2012, this youth risk behavior survey came out and sort of showed that about a quarter of our high school students were feeling significant sadness and hopelessness and depression, that more than a sixth of them had thought about or tried to commit suicide. But I think importantly, at least 75% of them had actually given some kind of warning of their intentions, which I think is important for us to remember. More recently, and post-COVID, UNICEF's done a survey again amongst our young people and found that more than 65% of our young people have had mental health difficulties. Frighteningly, 20% of the people surveyed didn't know where to access help. And probably even more concerning was that 18% of them didn't want to access help because they were afraid of what people would think. We know that self-harm is probably most common in the adolescent and young adult age group, with the typical onset being around 12 to 14 years. So 12 years old is grade 6, grade 7, that's junior school. So it's not even a high school phenomenon. It's actually fairly young kids, girls and boys. Quite often, I think people think that cutting is a girl thing, but actually boys do self-harm as well, sometimes in slightly different ways. So I think they've probably got slightly higher rates of doing things like burning or hitting themselves, injuring themselves in that way. And then in adolescents and young adults that are still exploring their gender and sexual identity, there's actually even higher rates of self-harm and suicidal thoughts. We know that the highest rates are amongst people with psychiatric disorders, so depression, anxiety, mood difficulties. And that's important because the WHO tells us that depression is globally the third highest disease burden in this kind of subgroup of people, and that suicide is the fourth leading cause of death in 15 to 29-year-olds. So, it really is quite a prevalent problem that we need to face head on, I think. This last little statistic is, I think, one of the most important ones. So a prior suicide attempt is the #1 risk factor in completed suicides. And so I think particularly for, I always used to get calls from casualties for another para-suicide. And if you can see my screen, you can see I'm doing little inverted commas, because these children shouldn't just be sent home as sort of, it was an impulsive attempt, let's just move on from this. That they, I think, are actually at quite high risk, and they need to have a really good supportive plan put in place for them. So when we're talking about self-harm and suicidality, what is the difference? The only difference really is the intent. So suicide is obviously the act of intentionally causing your own death. Self-harm is hurting yourself, but not with the intent of wanting to die. The problem is that it's really hard to determine intent. So I often tell my patients, I'm a psychiatrist, I'm not a psychic. Can't actually read your mind. And obviously the children that are at the highest risk of completing suicide are the ones that aren't actually going to tell you, because if they told you, you would stop them, right? And so they can actually mask completely, and we can miss things. And then obviously the other difficulty is that self-harm and suicidal thoughts can happen at the same time. Some instances might be with one intention and others with a different intention. So clearly there's quite a high association between self-harm and suicide. And if you ask any sportsman, ask any football player, ask any netball player, intent doesn't necessarily guarantee an outcome. You intend to score the goal, but it doesn't always work out that way. And so that helps us in a way when the intent is death, because if you don't score that goal, that's great, because then we get a second chance and we get to put things in place to help further down the line. But if the intent has not been to take your life, sometimes the outcome is accidentally the other way, and you can have accidental deaths. The other thing is the association of self-harm being a potentially unique risk factor in suicide. So Thomas Joyner, in his interpersonal theory of suicide, he explains that in order to complete a suicide, we have to want to die. So we have to have that desire, but we also have to have the capability to act on that desire. And again, generally humans, we designed to try and avoid pain and death. But in self-harm, there's two associations. So one, it's obviously associated with high emotional distress, and so high likelihood of having suicidal thoughts, but also it sort of desensitizes people to that actual acting on and hurting yourself and being able to follow through on that action. And so it really is sort of what we could call double trouble. So if people aren't trying to take their life, why are they self-harming? Why are these teenagers doing it? And the #1 reason that comes out in study after study after study is that it's a coping strategy. So it alleviates these overwhelming, intense negative emotions. So the teenagers can feel this intense negative emotion, they self-harm. It's almost like discharging static electricity. It just gets rid of it momentarily, reduces that emotion. They feel calm and relief, but then often the cycle will keep on going. The second most common reason that people who self-harm cite, in about 50% of people, is self-directed anger and self-punishment. So it's a way of actually sort of directing the guilt feelings and the negative feelings onto themselves. And I think that's really important because it does suggest that self-criticism is somehow implicated in the causality. And so we've got to think carefully when we're reacting to this, just think how guilt tripping and blaming and getting angry at a teenager might feed into that self-criticism, self-punishment kind of cycle. I think it's also helpful just to remember that their brains are quite likely to be wired differently. So we know that biology influences behavior. And it's a little bit like cancer research. We are knowing more and more things, but it also means that we know not enough things in a way. So there's lots of research that's looking at genetic factors, quite often around certain neurotransmitters like serotonin and the serotonin receptors. So looking at certain pathways in the brain that might be overactive or underactive, looking at the limbic system, looking at the stress response, so looking at different cortisol levels. And we know that if we do fancy research functional imaging, that the brains of teenagers who do self-harm will light up in a different way to controls who don't self-harm. So we know that the biology is a little bit different. And it doesn't really matter, I think, to this presentation, whether we completely understand what that biology is or not. I think the bottom line is that even though these behaviors might not make logical sense to us, these behaviors are working for the teenager in some way, at some level, forming a function. And generally, that's to alleviate distress, which still leaves us with the point that these are distressed adolescents and we need to be helping them in some way. I think it's helpful while we're talking about the biology to think a little bit why the numbers are so high in teenagers and young adults. Why are they at such high risk? And I think it's helpful just to think a little bit about what their developmental stage is and what's happening in their brain. So up until now, so in childhood, pre-adolescence, their little brains have been like little sponges. They're just absorbing information, learning how to walk, learning facts, learning how to talk and to think, just little sponges. And so their neurons have been making all of these connections all over their brain. But when they start reaching adolescence, they start individuating. So they start becoming their own little people. And so their brain starts doing two different things that it hasn't really been doing too much of until this point. So the first is synaptic pruning. So literally like pruning a tree. Your brain actually starts cutting those connections, the connections that it doesn't need to take into adulthood. And so that helps the brain sort of specialize a little bit. And at the same time, the brain is rewiring. So myelination is happening. So that's basically little insulation sheaths that are getting created around the remaining neurons. And so just like insulation around a wire makes it work more efficiently, the myelination helps those pathways work more efficiently. But this doesn't all just happen like that. It doesn't just happen all in one go. The brain has to do it in stages. And so how it works is that it starts from the bottom to the top and from the back to the front. And so things are going to develop a little bit out of sync. And how it happens to happen is that inside kind of core limbic area, which is responsible for our emotions and acting and reacting, that develops first. And our prefrontal front cortex bit that's responsible for thinking and for planning and for cognitive control develops last. And so it's basically like saying that the accelerator is developing faster than the brakes. And if you think a little bit about it, it doesn't really make sense, right? At the very moment when adolescents need to be leaving the nest and going out and being more independent, their brain actually makes them at more risk of making impulsive decisions, that cognitive control that's saying, hang on a second, are you doing the wise thing? It's not actually working yet. And so there's lots of theories about why that would be. The one that I think is possibly the most helpful is a social transmission theory. So if you think about it, when kids are little, it would make a lot of sense that when they're vulnerable, they're getting all of their learning and their protection and their provision from their families and from the systems that their families are putting in place. But what if your little family, what if your little tribe wasn't doing things as efficiently as other tribes were? What if you hadn't discovered fire yet, but the tribe next door has? What if you don't know about the coffee bean, but the tribe next door does know about caffeine? Could leaving your tribe offer new insights, and could it kind of take society and humankind to the next level? And so social transmission kind of postulates that maybe it does, that it's actually about survival of the species, because we can then innovate and learn new things. And so that's why adolescents are likely to want to leave the home and explore new ideas. The good news for most families is that they will eventually return with a little bit of a mix of what they got from their nuclear home system, plus some new interesting ideas that will take humankind on into the next kind of level of development. Unfortunately, it does mean that survival of the species doesn't necessarily mean survival of the individual. And so some adolescents might be at high risk for making impulsive decisions because this limbic system is just overriding everything else. So who are our more vulnerable teens? So some teens are definitely more at risk. Like I said before, prior suicide attempts are probably our number one. Having a history of some kind of mental disorder or difficulty, depression, anxiety, bipolar mood disorder, definitely priming our brain for that. Alcohol and other substance use disorders, I think, is an interesting one, because not only is it, I think, exaggerating the distress, because obviously an effect of alcohol or substances could be to aggravate anxiety and mood things, but also it facilitates that impulsive action, because you are more likely to act on something. That's why it's sometimes called Dutch courage. Family factors. So like I said before, there may potentially be genetic factors that get shared. So if there's a family history of depression or suicides or self-harm, there might be some kind of genetic predisposition. But also what's happening in the family. Is there conflict? Is there fighting? Are parents divorcing? Is there adversity, lack of social support, financial difficulties? We know children are more vulnerable when they come from those sort of backgrounds. Are there specific stresses? So a history of sexual or physical abuse is obviously a huge trigger. Bullying, any recent or serious losses, deaths, exploring sexuality, and particularly coming out in an unsupportive environment seems to predispose to high risk. And then social contagion as well. So what's happening around them? And I think it's worthwhile pausing in that one for a second. So if any of you had studied journalism, you'd probably heard of something called the Verto effect. So the Verto effect is basically a term that's been coined describing the influence of how the media depicts suicidal action. So it was coined because of this book, The Sorrows of Young Werther, which was published in the late 1700s by von Goethe. And in the story of poor young Werther, he suffers a romantic disappointment. And then I think rather romantically captured in the book is his suicide. And what they noticed was that after the book was published, there was the spate of young people who committed suicide in the exact same fashion as was described in the book. In fact, sometimes even wearing the same clothes as what was described for poor young Werther. And so this gets used as an example and in helping the media to report responsibly, because we know that there's often suicide clusterings around high profile suicides. If you think of Kurt Cobain or Robin Williams, And so organizations like SADC do this media kind of training, and people learn about it when they study journalism. But I think it's helpful to just think, who is curating these teenagers' news feeds? They're not watching the 7 o'clock news, and they're not doing it while they're sitting with you anymore. They're on their phones and they're scrolling through influencers and TikTok. And so I think we really just need to keep that in mind of what is going into a teenager's brain. From an adolescent perspective, I think sometimes people think that self-harm is this TikTok phenomenon, and they're seeing it online and they're all just jumping on the bandwagon and trying it out. But really, I think the kids who are at high risk, self-harm is a hidden epidemic. There's often a fear of stigma associated. They're fearing the reactions of others. They're concerned about being judged. They don't want to be viewed as a burden by their parents. They're often ashamed of their behavior, and it can be a really difficult behavioral pattern to break. And so often they hide it from us. And so when we're thinking that, what are we looking for? When we're lucky, they come and they tell us that they're distressed and they're having a hard time. But sometimes it is about looking for the clues. So what might we notice? So we might notice that they're hiding injuries and scars. So often they'll be injuring on their inner forearms or on the upper thighs. And so we might see it's summer and everybody else is in a swimming cozy, but they're wearing long sleeve clothes, even though it's so hot, or avoiding swimming. So sometimes I'll get teachers that say to me, they're concerned about someone because they don't want to get into a swimming cozy, and there's only so many times that you can have your period in a month, and that's because they're wanting to hide the scars on their legs. Usually, though, there'll be other signs of mental distress as well. So we're looking at major mood swings, sustained irritability, particularly increasing isolation. So it's normal for teenagers to want a little bit more privacy and to be in their own room. But when there's a marked difference in functioning, when they're withdrawing from activities that they would normally enjoy, when they don't want to go for their horse riding or their guitar lessons, where they are not going out with friends anymore, where they don't want to go to school, or there's a huge drop in academics, we need to be concerned. Also changes just in day-to-day functioning. So big changes to sleep, more than usual, less than usual, changes to eating, changes to self-care, teenagers who just suddenly aren't washing their hair or bathing, aren't brushing their teeth. We really need to take those things seriously. So if we do become concerned, I think it's helpful just to pause for a second and think how we would react. So like I said in the beginning, self-harm, suicidal thoughts, any kind of not wanting to survive goes against that innate survival instinct that we have. And so it is a threat to our belief system. And often adults respond with a stress response, which I think is normal. Think about how you would respond if you were in Gauteng and came across one of those escaped lions, or if you were mugged at knife point. Quite a common one would be responding with fight. So we all know fight and flight, getting angry. Think about how you'd respond to a little toddler who wandered off. First instinct is, I was so scared. How could you do that? Never ever do that again. And so sometimes when we notice the self-harm, it's a similar kind of a reaction. What will people think? Are people going to see your scars? What were you thinking? The other one is flight. So just complete avoidance, changing the subject, finding it really hard to sit with the distress, not wanting to hear what's happening, focusing on something else, getting the teenager to be super busy. If they can just do all these things, then maybe they won't think about their distress. The other two that I think people maybe don't think about quite as often is the freeze response. If you're a little steenbokkie and you stumble upon a lion, you are going to freeze. It's literally why they're called steenbokkies, because they turn to stone. And so this is where we get stuck, where we feel numb, where we can't make decisions, where we just feel overwhelmed and don't know what to do next. And the other one is fawning. So people pleasing. You might do that if a mugger was coming at you with a knife. Well, what can I do for you? What do you want? And so sometimes I think we get a bit stuck with teenagers who self-harm, is that we just want them to stop. And so you don't want to go to school? Cool. Don't want to go to therapy? That's fine. Just don't self-harm, even when it's not necessarily a helpful strategy. And I think all of these are natural reactions, and people may respond with that, but they might not be the most helpful for the teenager. So I think what we are really wanting to do is face the threat. So our other F is to face the threat. Any self-harm, any suicidal thoughts that are voiced, I think are always a cry for help and should never, ever be ignored. And I think the important messaging to get across to the adolescent would be, firstly, to acknowledge their distress, because no one hurts themselves if they're not distressed, that they're not alone, that there is a system around them, that they're not the first person to feel this way, and that we've got them, that somehow we can support them, that our main concern is their safety, and that we are going to try and ensure that in the best way that we can, sometimes even in ways that they might not want. So I'll often say to an adolescent, and even the most depressed teenager will kind of manage a bit of a wry smile when I say to them, I would be a really bad doctor if I was okay with you being dead. So I need to not let you do that. And I think it's important for them to know that almost any circumstance, any decision that has been made can be changed except for death. My magic wand can do a lot of things, but it can't help with that one. And I think right up front, we need to be explaining the difference between confidentiality and where we're going to be communicating. So if you are a coach or an aunt or a parent of a friend and you have sort of discovered this for the first time, teenagers will often say, but please don't tell my mom and dad. And we need to be able to say to them, usually we'd like to keep your confidence, but in a case of life and death, in a case where you're at risk, we can't actually do that. We do need to have a team around to support. So what do we do? What is our plan here? So I think for people who are the first people, the first responders, think a little bit about how we would feel in the case of a fire, right? So we've identified that there is a bit of a crisis, a threat. We are the primary contact. So first things first, if we can, we need to try not to panic. We need to pause, take a breath, think of our own stress responses, how we reacted. I do think that preparation helps. So think about why we do fire drills. Think about why we have to listen to where the exits are every time we get onto a plane, because preparation helps. It helps us to think more clearly. And so I'm hoping a little bit that, listening to a talk like this evening will help with a little bit of preparation of what we could potentially do. We always want to be assessing, what is the situation? What is the risk? What are the safety implications? We're doing triage. That's basically what we're doing. And that's going to inform our further management. I think we're always wanting to mobilize support, but the degree of crisisness is going to inform what level of support that needs to take. So I normally explain to my patients that, I talk about the DEFCON levels. So if this is DEFCON 1 and it's sort of superficial injuries, it's only happened once or twice, the distress levels aren't at crisis point, there's no suicidal thoughts, then I think a really good place to start is with your GP or your family doctor or even the school counselor. I actually think a GP or family doctor is often a really nice place to start, no matter what the kind of degree of crisis is, because often, especially if it's a trusted person that the adolescent's known for a while, they'll be able to tell the doctor something that they might not necessarily want to disclose to their own family. And remember what I said in the beginning, their brains are primed to be listening to outside influences at this point. So you want to make sure that those outside influences are people that you trust, and a GP generally is. But, if it's just a mild risk, that's probably going to be enough. If it feels like this is an entrenched pattern, or the risk is much, much higher, or there's active suicidal thinking and planning, then we obviously need to escalate that to more specialized care, to more supportive therapeutic care, potentially to a voluntary admission where teenagers can receive a lot more kind of help and containment all in one go. And then, of course, if it's DEFCON 5, if it feels like there's no containing right now, if there's been an actual injury, an actual overdose attempt, then obviously we've got to act right now. There's no waiting till tomorrow. In South Africa in general, for medical complications, you can go to any casualties and they can suture and stitch up and check for medical things, but generally they can't admit involuntarily at any rate, for psychiatric reasons. If it really is at that level, sometimes we have to go within the state system. And there's, it sounds really scary, I think, for a lot of parents, but there's checks and balances for that. So anytime that we're wanting to admit someone who is so psychiatrically ill that they do not want to be alive and need to be forced to take treatment, we have to make sure that that risk is real. And so for anyone, not just teenagers, we make sure that you can't just take your mother-in-law to casualties on a Friday night and say, but she's crazy, admit her, right? We need 2 independent mental health care practitioners who are not being paid by the person who's saying that they we need them to say that they agree with that. And so the state system affords us that possibility.
I didn't catch that. Could you try again?
Siri's trying to talk now for me, and I don't know how to get her to go away. There we go. I think I've managed to get her to go away. What happens if we are the next people in line? So what happens if we are the people that are being referred to? So secondary care services. Again, I think it's very similar. We're going to assess the risk and safety. People will often ask me, is it okay if I'm the GP? Can I ask about suicidal thoughts? And the answer is always yes, absolutely yes. Study after study shows that there's no risk in talking about suicide in a supportive environment. The risk is missing those thoughts. We're going to be looking for comorbid disorders like depression and anxiety. We're going to look for the triggers and the facilitators. In psychiatry, we love talking about the P's. We're looking at precipitating factors and perpetuating factors. And that's obviously going to help us inform our management. I do think that having a team and having a structure is always helpful. So having a framework, I think, does a couple of things. So it helps us to manage our own anxiety, and it empowers the teenager and the parents to be involved in the process. And it helps us, I think, kind of clarify where the different collaborating role players are going to be involved. You know, there's the school, there's sport coaches, there's therapists, there's potential medications. So this is just a little example of what my approach and my framework is. Obviously, everybody will have their own different way of doing things. It doesn't come out of a textbook. This is just an example of what I do. So how I normally explain it to the teenager is that, like I said, suicide, self-harm thoughts, depression, often these things have some kind of biological genetic predisposition that'll make the teenager more vulnerable. And that's like saying they might have inherited some wonky planks, like on my bridge over here. But it's almost always a combination of the wonky planks plus the load that's gone over the bridge. So you ride a little bicycle over and it's going to be okay. It doesn't matter how many wonky planks there are. You put a 10-ton truck on a fairly substantial bridge and it's going to be too much. So plan number 1 is always for us to try and identify what is the load on the bridge. So we look at things like external stresses, so major life events, traumas, deaths in the family. Never underestimate a breakup in a teenager's life, because that is a monumental event. Catastrophic events in the environment. Think about COVID, think about the riots in KZN, and how that impacted on some teenagers. We think about the different environments they're in. So we think about what's happening at home. Is there anything that we can get off the bridge at home? Are parents having a hard time? Is there conflict at home? Is there a divorce happening? Is a parent ill? Does someone have a terminal illness? Is there something happening with one of the other siblings at home? Is there financial difficulties, economic adversity? What can we try and get off the bridge there? We look at what's happening at school and kind of in the periphery as well. Are there academic difficulties? Imagine a child, say, with ADHD who is trying incredibly hard to do as well as they can, but just can't finish their work, feels like they're putting in the effort and just not getting the results. Think of how disheartening that could be, and think about how if we treated that or got concessions for extra time, how that might alleviate some of the strain. We think about the social context, so things like being bullied, social exclusion, loneliness, big friendship difficulties, or even just having too much stuff. The kids that just are overwhelmed, they're trying to get into university, or the grade 7s who are trying to get into a good high school, and they've got to have good marks, and they've got to do community service, and they've got to do 3 sports, 3 music instruments, and an extra art class. Just think how overwhelming some of that might be. And if we could alleviate some of those practical stresses, how some of their distress might get reduced. But also intrinsic things. So we've got to remember health and lifestyle things. So if there are illnesses, overactive thyroid, underactive thyroid, iron deficiencies, anything like that, we want to manage that. We want to think about the impact of potential substances, so illicit substances, but also prescribed substances. So think of side effects of certain medications that might increase suicidal thinking or depression. We also want to make sure that the sort of physical attributes are all under control and balanced. So we all know if we're not sleeping, if we're not eating, if we're not exercising properly, our bodies are more vulnerable and we feel worse the next day. So we want to try and promote good sleep cycles. We want to potentially even use something like medications to try to help that. We want to make sure that they're eating. We want to make sure that they're getting out into nature and not sitting all day on their screens. So we want to promote all of those lifestyle things. And I think those are particularly helpful and important for adolescents, because it does help them with a sense of agency and of working towards a common goal with all of us. If that's not enough, right? So once we've taken as many things off the bridge as we can, sometimes that's all we need to do, but often we need to do more. And particularly for something like self-harm, which is a destructive coping mechanism, I think it's helpful to empower teenagers with skills to cope. So teaching them skills and strategies of what to do when they're distressed, what to do when they're anxious, what to do if there's conflict. And that's kind of like tying ropes onto the bridge to make it stronger. But also the other thing that therapy can do is that sometimes there's something that you can't get off the bridge, right? It's something historical, something that happened in the past, or entrenched, relationship patterns. Then getting a healthy perspective from a good therapist, I think, is really important. You can go into a session with something feeling like a 10-ton truck, but a good therapist needs to help with perspective so that you shrink that down. So it's sort of Mini Cooper size. And so the load on the bridge gets lighter in that way. I particularly want to mention DBT, dialectical behavior therapy, because I think it does come up really commonly in the context of suicide and self-harm. So it was developed in the 1970s by Marsha Linehan, specifically looking at people with borderline personality disorder. And that's a disorder and personality traits that speaks to emotional relationship identity instability. And so there are all skills and strategies and an approach that's specifically designed to increase emotional and cognitive regulation. So I think it's something that a lot of adolescents can really benefit from. But there's no one size fits all. I think fit is really important. We need to assess what kind of approach and which therapist is going to fit for this particular adolescent. Sometimes all of that's also not enough. So we've taken our load off, we've put our therapy in place, like tying on our extra ropes, but sometimes we do need to use some medication just to reinforce those wonky planks. So medication can form the scaffolding. Generally, we're treating the co-occurring disorders. So we're wanting to treat the mood or treat the anxiety. It doesn't always have to be a psychiatrist. It can also be a trusted GP or a pediatrician. But I think the important thing is to remember that anything that can do good things can also do bad things when we come to medication. Anything we put into our bodies, actually, if you put garlic on your pizza, you might have stinky breath tomorrow. Might be worth the risk if you're just chilling at home with a family, maybe not if you're going for a job interview. And so we always need to decide what's the risk-benefit ratio. And so I think monitoring is really, really important when it comes to that. Also think the other really important thing is that particularly with suicide and self-harm is that it is a really distressing kind of topic, and the distress for the patient is so high that we don't want to be dealing this just by ourselves. A safety net is only going to be as strong as its connections, and so we need to all be communicating as a team. That's helpful for the patient because we each are playing our own unique little role in the story, but it also alleviates strain on each individual role player. Mom and dad aren't alone, the teacher isn't alone, the counselor isn't alone, the doctor isn't alone. I think there's also other outside resources that are helpful just to bear in mind. So organizations like the South African Depression and Anxiety Group have multiple helplines, multiple things on their website that can help and assist families and individuals. And I think we just need to pause for a second and just think about us as well, because, you know, it's not just about the teenager. There is a system around them. And I think it's okay to not be okay if your child is not okay. I think it's also important to acknowledge that it's also okay to still be okay. You can still go have a cup of coffee with a friend and enjoy it and have a laugh, and you don't have to feel guilty that your child is having a rough time. There can be moments of both. I also think that it's important to remember that perfection isn't necessary. So if you have reacted with fight or flight or have made mistakes, that's okay. Going back to Donald Winnicott, he also said that, you know, there's no such thing as a perfect parent. We have to have good enough parenting. And it's important just to be able to repair that and to acknowledge our mistakes and to model that. I think we do need to remember our own self-care, so making sure that we're sleeping and eating and exercising and getting into nature and doing what feeds us, whether that's gardening or listening to music or going for a run, and to remember that we have a community of resources around us as well. And not all of those resources cost money. You know, we have access to therapists and doctors of our own, but also just getting into the sunshine and enjoying the nature might also be something that we could use. And so I think my take-home messages at the end of the evening is really just that this is a triggering and a frightening topic, and that's okay because it goes against our natural survival instincts. But that we do need to remember that these behaviors are serving a function. Even if they are dysfunctional, they are designed to alleviate distress, and that we need to really work with that underlying distress, that there are biological underpinnings, that we need to think about our own stress responses and how we are doing. To have a framework can often help with those anxieties, to mobilize as much support as the teenager or we need, and that we do really need to practice and model self-care. Yeah, I'm pretty sure that there's a couple of questions, and so I'd be happy to answer what comes up.
Thank you so much, Maren. Really been very insightful and coming up with a lot of practical points and direction in this very difficult topic. So let's just look at some of the questions. Okay, so here a question: does the person decide to die, or is it the illness that makes them want to die? I don't know if that is a question that you can answer, but maybe try.
So that is an incredibly difficult one to answer, because again, it comes down to knowing what's in that person's head. I think it's generally a combination. So I think people are more likely to want to die when an illness makes them want that, because it does go against our instinct. So sometimes people aren't, sometimes they do have that cognitive capacity. Sometimes people choose because of other reasons. There's financial problems, or they feel like it's a decision at the time and it's not the illness doing that. But I think the more common answer would be that the illness does change the thinking patterns to make them not think in kind of what we would think of as realistic ways.
Yeah, then I think an important question here is the impact of technology. I want to add my little bit on it, but that's a bit different. It's substance abuse and the use of cannabis. You mentioned the wiring of the limbic system and the prefrontal system. So maybe expand on that a little bit if you can. Just what is the influence of that specifically? And then technology, because all our young people are constantly, engaging with technology these days. Do we know anything negative impact of that?
Yeah. Okay, so the two things are looking specifically at substances like cannabis and then at the technology. Is that the kind of question. So with the cannabis, I think that could be a whole different talk on a whole different evening, particularly since I think it's becoming more and more normalized, that it's not this big illegal thing and that it is easier to access. But in child and adolescent psychiatry, we are pretty terrified of cannabis because we know that in this particularly vulnerable developmental stage, that actually the risk, I think, is phenomenally high. We know that it can trigger higher rates of things like psychosis and schizophrenia. And so I do think it is really, really dangerous for a particularly vulnerable brain. For technology, I think it depends a little bit. So technology can be a really helpful thing. And we know that if we use it responsibly, that it can, open up so many avenues and really help in a lot of respects. But I do think, again, for vulnerable people or where it's misused, and a little bit like alcohol as well, some people are just genetically predisposed that alcohol is going to escalate and end in addiction. I think there's some people where technology, their brains are just primed to not be able to kind of turn off, and it does escalate, where it does release dopamine in problematic ways, and where it really can kind of rewire those areas. But again, I think that's potentially a whole different talk for a whole different day.
I think we've touched on, or you've touched on that, the peer review. Where is it? The peer control. Where is it? The friends are doing it there. Maybe just a word on that, on the influence of peers on self-harm.
Yeah. So I mean, it definitely is. It links a little bit to that whole Verto effect, doesn't it? So yep. When it's spoken about and when it kind of comes more into their consciousness, I think there is, it is definitely a triggering phenomenon. But also it goes with that heightened anxiety as well, because if your friend is self-harming, they're also having a hard time and you're concerned about them, and it just adds onto that load, onto that bridge. But then you also see it as a potential coping strategy, and then are potentially more likely to try it out. So some will and some won't. Some will completely shy away from it because it is so frightening and they're so concerned for their friends. But yeah, I do think there is a link.
Yeah, there's a question on the referral to psychologist from a community health nurse, but I don't think we can touch on that at this stage. I work with a 12-year-old client who's severely depressed. They've reached out to parents on a number of occasions. They've consulted a professional regarding medication, but they don't take the situation seriously. He can technically consent to his own medical treatment, but logically, how does this work? So maybe that's more mental health.
We've got some lovely questions here. I don't mind trying to answer a few of them if we've got a couple more minutes. So around, where should I start? Okay, so can I just answer one or two of the questions as I read them?
Yeah, cool. Sure.
Okay. So the one question is, at what stage do I as a therapist refer to the psychiatrist? So when therapy fails or immediately when a teenager has suicidal thoughts? So I think when a teenager has suicidal thoughts, I'd probably be more primed to saying, let's get another person involved, right? So I wouldn't necessarily see that as a treatment failure or a therapy failure. I just see it as, different degrees need different intervention. If you have asthma that doesn't really impact on your life, you can just have a little Ventolin pump. When it's reaching life-threatening proportions, you're probably needing 3 or 4 different interventions and medications. So I'd say I would probably rope in a GP or another practitioner when it feels like it's getting to sort of suicidal thoughts, and certainly if it feels like the therapy process is stuck or not progressing, I'd be more likely to get someone in sooner rather than later. Then there's a question from a mental health nurse asking about diagnosing teenagers with borderline personality and bipolar. And so I mean, certainly for bipolar, we can and do diagnose even pre-adolescents with that if they meet the criteria, and it needs to be the actual proper criteria of episodes of mania or hypomania and depression. For borderline personality, it's not like they have no borderline personality traits until they're 17 and 364 days old, and at 18, suddenly it all changes, and now we can make that diagnosis. But the reason why we are quite reluctant to make that diagnosis in adolescents is I think adolescents don't have personalities yet. They're still developing their personalities. They're not entrenched behaviors yet. They're not entrenched strategies and emotional kind of dialogues. And so we can change that and shape that. And so I will more likely highlight that someone has borderline personality traits we want someone to assist them with, but I'm less likely to diagnose a personality disorder until I feel like they're adults and have a personality. And then just in terms...
Okay, I've found this on the web for personality traits that we want someone to assist them with, but I'm least likely to diagnose a personality disorder until I feel like they're adults.
I can't get Zoe to go away.
Where it comes from.
Okay. And then I think just the last one here is about a 12-year-old who's severely depressed, and about reaching out to the parents who don't seem to take the situation seriously. That's a really tough one because 12-year-olds can give consent, but obviously they live within a system. And also, if their mental state is so severely compromised by depression, they might not be able to give consent. And so I don't have a direct answer for that one, other than to say it is an ethical and an intervention dilemma, but that I would probably just sort of get the support of the team around you to see if there's other avenues of support.
Yeah. Fantastic. I think, I don't know if there's more time left, maybe 2 minutes left, maybe 1 or 2 questions still. What about how do we get parents and schools on board for treatment? My experience has been that parents and school boards are quick to give up on children and are quick to diagnose with impulsive or conduct disorders.
Yeah.
That's more or less what you said just now, that you need to get the team around you, isn't it?
Yeah, and I think maybe also helpful just in thinking that, you know, I think it is a little bit sometimes the stress response of the school board and of parents, right?
Yeah.
Where they feel like this behavior is really difficult and overwhelming and they don't know how to manage that. And so sometimes coming from a more supportive kind of approach, putting as many things in place to assist the school, to assist the other children around the child who's really struggling, might in the end help the child to access care. But it really is a tough one.
Yeah. Yeah, I think there's lots of comments on appreciation of your presentation and, you know, what was discussed here. I think the question is, will you be leaving behind contacts and or a program that parents or social worker can access? You see a suicide support center that is open to parents and children. I think you said SADC, people going through this process. I don't know if there's anything additional you want to add there.
Yeah, I mean, I do think SADC is a really great place to have a look for outside resources. They've got lots of information on this topic, lots of helplines, access to support. And if people are, you know, interested in looking into further things, that would be a really good place to start.
Yeah. I think at this stage, I think we have to conclude this presentation and this webinar. Let me take the opportunity of really thanking you very much for the way that you approach this topic and really giving us pointers and you know, helping us to understand and also to approach this in a way that is beneficial to all parties. Miriam, thank you so much. I'm sure we will have more topics on children and children-specific issues that going forward. But this was a wonderful introduction to how we need to think of children and how we need to approach a very difficult situation. Thank you, and everybody else, please check our websites and you will be receiving your CPD certificate soon. Thank you and have a good evening. Thank you, everybody.
Thank you.